So there's been a controversy for patients who have hormone receptor-positive, HER2-positive breast cancer, whether these patients need to undergo ovarian suppression. In soft text, we saw that there was a greater benefit of adding ovarian suppression to tamoxifen in the patients who had HER2-positive disease compared to those who had HER2 negative, but it's worth noting in that study that only about 15% of patients had HER2-positive breast cancer, and also about 60% received HER2-targeted therapy. So today we saw data from the HERA trial, which is a study that was published back in 2005 originally, and it showed that patients who received ovarian function suppression did better in terms of 10-year disease-free survival as well as 10-year overall survival compared to receiving tamoxifen by itself. And also the subgroup of patients who received an aromatase inhibitor along with ovarian suppression did better than ovarian suppression plus tamoxifen. And so these do offer some support for utilizing ovarian suppression. I will say that there are some unanswered questions, including what were patients' adherence to medication, how long did they take their ovarian suppression, and also the big picture is that treatments have really changed since 2005. We have TDM1, we have pertuzumab, we have neratinib, and there are a number of other HER2-targeted agents that are coming down the pike. And so ultimately, for optimizing our HER2 therapy, do we need ovarian suppression? And what I concluded was, really we can think about this for our highest risk patients, those patients who get neoadjuvant HER2 target therapy and chemo and have significant residual disease after, like T3 tumors or those who have significant nodal burden, that those would be the patients for whom I would think about ovarian suppression, recognizing that the HER2 agents are doing a lot of the work.